Hello, my name is Joyce, and my subject matter today is going to be whitening. It's like a TED Talk. It's going to be quick, concise, but I'm going to give you a lot of data. If you want to follow me on Instagram, I'm Smiles by Joyce, and there's a lot of photographs there, and I could use some friends. So please join me on Instagram or Smiles by Joyce website, and then the publication pages, you'll see I'll have some articles on whitening in there. Okay, you are in the middle of my screen. Tong, for some reason. How do I get you out of my screen? There you go. Okay, I'm sorry. Now he's not. It's down here. All right, we love Zoom. Professional tooth whitening. How do we maximize this breakthrough technology? So here's a picture of all of my patients with me in the middle of it. And they're really actual patients. The one on the right of me, she had 10 veneers placed. The one on the left of me, she has, is this working? There we go. She had 2 veneers placed. This person over here has some implants, and she has 1 tooth placed with porcelain. But one thing they all have in common is that they were all whitened first. Comprehensive dentistry is combining the art and the science with the goal of improving health, aesthetics, and function. Let's look at the word aesthetics. What does it mean? The nature of beauty. We're not inventing anything new. We're copying something that we think is perfect. So this is me. I had yellow monochromatic teeth. When whitening gel came out, it was proxy gel. It was used and just to keep your teeth fresh and your mouth fresh. And they found out when the brackets came out for ortho that, it was whitening. So the minute I could get my hands on it, I utilized it in my mouth, and I wanted really beautiful white teeth. Now, I had monochromatic teeth that were yellow. That's the most predictable when you're going to have a good result with whitening. The least predictable is tetracycline and striped teeth. So this patient presented after he had tried whitening everything he could possibly do years ago. And so he was ready to have veneers placed. So we placed veneers. And what was great about this is that he didn't want to change the shape or the form of his existing dentition. So we could do a minimal prep. We didn't have to open up any contacts because we weren't changing the widths of the teeth. And right where the black area was from the tetracycline, thank God it was in the middle third of the tooth, I made a very deep preparation there to give room for the ceramics. We can use an opacious material in there, and we used a ceramic that we could use over the top. And this case came out beautiful, very aesthetic. We improved upon nature, but that was 2004. Today, because we have dual whitening, we can do at home first and then an in-office treatment after, or vice versa, with multiple treatments of at home. And now we can see that we can get tetracycline teeth even whiter. So some of these patients do not have to go to porcelain laminates. What about this case? Where does your eye go? What dentistry has been performed? She has veneers placed on the upper and natural teeth on the lower. But when we did this case, we whitened the lower teeth first, and that dictated the color of her upper dentition when we finished the laminates. So these are cases of aesthetic dentistry. So let's talk about cosmetic and what that definition is. Cosmetic is a superficial measure to make something appear better and more attractive. It's a decoration of the smile. So a grill is cosmetic dentistry. And on the right screen here, this patient, I did those teeth. They're really monochromatic. They look like piano keys. They don't look real. I mean, they're very media generated. And a lot of people, they want monochromatic white teeth that walk in the room before them. So we have cosmetic patients, we have aesthetic patients, and how do we know who our patient is? And how do we know how white they want their teeth to be? Color is patient driven. You want to compare the color of the eye with the color of the teeth. And if the teeth are whiter than the sclera of the eye, sometimes it doesn't look good. So I'm taking these photographs, sending them to my patients when they're having veneers placed, and they're in the provisionals to ensure that they're not going to come back and say, hey, you made my teeth too white. I send an email to them. They can think about it. If they want them a little warmer, then we can add some staining. We know what color to go. We have to be careful also when we whiten. This is me. When I first started, I would over whiten my teeth. It wasn't good. I couldn't even find a composite that would match the color of my teeth. And you can see I added bonding on my number 6 tooth because I grind on that side, and it was yellower compared to it. Today we have whiter composites, but we have to be very careful with how white we whiten the teeth. They can become blue looking at times. Whitening, though, is the entry point for all of my cases that have natural dentitions, natural teeth. As we get older, we lose lip volume, tissue elasticity, the lip mobility decreases. The maxillofacial exposure changes, it gets less. The lip lengthens, the display of the teeth change, and the teeth become darker. Here is a graph of what happens when you're 30 years old. You show 3.37 of upper and a half of lower. By the time you become 60, it reverses itself. And this is a morph that shows what happens as we get older. So as we get older, we show more lower teeth than upper teeth. We have to remember, and everybody knows, high smile line, you show everything. Medium, you show everything except the zenith, and low, you don't show any pink on the top teeth. So we always have to tell our patients, show me your gums, show me your gums. Try to get them to smile. Then we look at the lower teeth. Low smile line doesn't show anything. Medium shows the teeth without the zenith, and a high smile line shows everything at the gum line. When we have a high smile line on the upper and the lower, then we need to think about whitening. Then we have to look at lip mobility because the lip is moving all over the place. When you measure the upper lip length at rest from the base of the nose to the bottom of the lip, females are 20 to 24 millimeters and males are 22 to 24 millimeters. And the upper lip mobility is usually 7 to 8 millimeters. If you have too short of an upper lip, a lot of tooth and gum show, as you can see in our football player. And if you have too long of an upper lip, no teeth show it all. Now I use video, and I have my patients talking to my iPhone.
I do not see my lower teeth when I smile.
I only see my upper teeth when I smile.
I only see my upper teeth when I smile.
Say shush.
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 Like this. Okay. And then they can really see what's happening in movement. And I have patients that come in and think if you can reconstruct their teeth on the upper and make them longer, that they're going to show a lot more teeth when they talk. And sometimes I have to use video to realize I can make those longer, but you might be better off with a lip lift because as you've aged, your upper lip has gotten longer. So we have the use of shush. So the patients can see if the upper and the lower dentition shows. That's a still photography if you don't want to use video. So what's in the aesthetic zone? And when I talk to the patient, I get a lot of pushback. And I think that I have to constantly listen. First listen and then be heard. Because objections are a really good thing to have because they're going to ask all kinds of questions. How much is it going to cost? How long is it going to take? Is it going to hurt my teeth now? Is it going to hurt my teeth later? Questions are really good. They're giving you permission to answer their objections. Objections are a buying signal. It's a huge untapped revenue source. And it's really all about you and your team and how you explain things and how you create value with the photography that you use. So my patients really need a lot of help by my team members and a lot of assistance with the questions and with the photography. So we show them how to hold the retractors. I put the before pictures in the same plane, upper and lower as a dentition. And I use my iPhone and just take a picture, a close-up picture there. That's my before. Then I find the picture of a color of what I think matches, and I put it on the left side of the screen where the number 8 tooth is, and I take another picture. Then I use the photography again when they're completed with the whitening, and this patient went from an A2 to an O2O, and it was a dentist that did not believe that an at-home or at a Zoom whitening with the light was going to make a difference in a smile, and this is the post-op, immediate post-op of the picture of what occurred. So here's how we take the picture, and then we take that picture and email it to the patient. So once they have it in an email, they go, oh my gosh, I thought they looked better, but now I can really see it with the before and the after picture in front of them. Then I tell them to put it on Instagram and I ask them for a Google review. So this really helps because when they're happy, then hopefully they'll say something positive and I don't have that many Google reviews, and it helps. It helps your practice with marketing and creating value. Now, 8 out of the 10 patients, they don't really like their teeth. They don't like the yellow in their teeth, but only 6 of them have used over the counter. And only 2 have gone to the dentist to get their teeth whitened. So a lot of them go to the pharmacy. And no matter what happens, those 6 over-the-counter patients, they don't really like it that much. I would say, how's that working for you? Do you think you're getting any whiter? I want to convert all of those people that are going to the pharmacy to getting over the counters into take-home trays or an in-office procedure. How does white make you feel when you smile? It makes you feel young and sexy. And everybody's on Instagram, everybody's on Zoom calls. And this is how it started with Jessica Rabbit in my generation. And now it's the Kardashians. They're looking at themselves. They have to be white and big teeth. So they deserve white teeth with custom trays. That's where I start them if they will wear the custom trays, because some of them are not compliant, because they're really comfortable and easy. And I utilize custom trays. And so I use myself as an example. Now, they also can double as desensitizing trays. So if someone has sensitive issue, then they can wear desensitizing gel inside of the trays for a couple of weeks before they could do an at-home procedure. And then some people use it for fluoride treatments inside of their trays. So I give my patients their models, and the investment, I tell them, can last a lifetime because you're only doing it once, and then you just have to buy the whitening gels in the tubes. Now we have digital, and so you can scan and send it and have a digital model made. So you can do it that way also. They always ask, how much is it going to cost? Well, I say it's cheap compared to over-the-counter products or full mouth reconstruction. I tell them it's a one-time investment. Now, this is a different company. It's called Opalescent Go. This is a company that makes these trays, and so they don't have to have their own trays at the house, and they can take it, they put it over the top, they push it down, they peel the green off, and that's what it looks like on the top. They do the same thing on the bottom. Push it down, pull the green off, and this is 15% hydrogen peroxide. This patient likes this product line better.
I believe these bleaching trays are better because they form better to your mouth. That way they stay on longer, and it's only for 20 minutes. So after those 20 minutes, you definitely tell a difference.
If you have ill-fitting trays, the saliva is going to dilute the gel and you're going to have gingival irritation. So it's really important that the trays are made properly. The fit really matters. You have to take your model and you have to thin it, and it has to be horseshoe in the middle. Once it's like that, you put it on the machine, and then the heat on the top, the plastic, has to come down when you put the heater on it 2 inches so that it looks like this. Then you slam it down over the model, and you can't touch it. You have to let it cool. So you can't take it off early because then it won't be tight around the model. You can trim it short or you can trim it long, depending on what your system is for your practice. You can trim it long, which is what I like, and then some people scallop it. When you have it long, for me, it's very retentive and it's more comfortable. I always tell my patients we can trim them shorter. You have to make sure, though, that you don't put too much whitening gel when you trim them long, because it will ooze into the gingival margins. And you don't want that, because that's where you're going to get the white spots. Now, you can also put reservoirs if you would like. And that's what opalescents, they like to have the reservoirs. And that helps. But the literature now says that you don't really even have to have reservoirs. So you can almost always figure out either way to do it and whatever works in your hand. In my case, we're not taking the time to make reservoirs anymore. Then the patients ask, what do we do and how do we clean them when we take it off? And I just tell them to rinse it and brush it and then put it back in their case. We can also use our intraoral scanners and produce a digital file. And when we produce a digital file, it can be STL monochrome or ply color. And once the file is completed, it looks like this. And then we can send it to Philips Zoom Delivered. And it is a link with IIS Inman Orthodontic Lab to the scanner portal. And once it gets there, they will make the model and they will make the whitening tray. And the patient, in less than 7 days, usually a couple days if it's on the weekend, if it's before a weekend, they will get 6 syringes and custom trays delivered to their house. And then you don't have to do anything about making the trays. And this is what they'll get. The next question they ask is, how long is it going to take? Then I have to start to think, I'm a dentist. What kind of stain am I looking at? This is where we have to use our brains. What is the cause of their stain? What is the etiology? Is it genetics? Is it tetracycline? Is it smoking? Is it coffee? Is it caries? Is it discolored restorations? So we're going to do a bleaching science overview. The dominant chromophore effects theory in 1993, which was in an article published in Inside Dentistry by Levine, there are color molecules and they're called chromophores and they all join together. Chromophores collect on the surface of the tooth. Extrinsic stain diet is removed with a prophy when you get your teeth cleaned, or toothpaste with an RDA below 70. That's on the outside. It's extrinsic stain. Then you have intrinsic stain that's on the inside. This is where the chromophores collect on the inside of the tooth. Tobacco, coffee, genetics, tetracycline. These are the harder ones to remove, the intrinsic stain on the inside. We have high density stain molecules. They absorb light and they appear. So when we look at a leaf, what we're seeing is white light comes into the leaf. Then what's reflected from the leaf is green light, and that's why we are seeing green. So when we look at teeth, white light is coming in to the teeth, and then we see yellow coming out. So what happens is a hydrogen peroxide reacts with a high density stain molecule. It converts the dense stain to a simpler molecule. It breaks the carbon chains and it makes it 2 simpler molecules. These simpler molecules decolorize and they fade the stain. So once they're broken, they're not the same anymore. It changes the light absorbing and reflection color of the tooth. So once they have been pulverized, your eye looks at your tooth and now they see white. The hydrogen peroxide boosts the rupture of the stain molecules. There's 2 products though, 2 product lines with hydrogen peroxide. And this is what becomes very confusing. So hopefully I can clear up some of this confusion. We have carbamide peroxide, and then we have hydrogen peroxide. Hydrogen peroxide, we all know this from school, is H2O2, and it breaks down into water and oxygen. And it does it in seconds, very, very, very quickly. It permeates the dentin and the enamel, and the reaction is complete within 30 to 60 minutes. So it's quick and it's fast. Now the carbamide peroxide, it breaks down into 3.5% hydrogen peroxide first. And then that breaks into water and oxygen radicals, plus a byproduct called urea. Now this permeates into the dentin and the enamel, it diffuses into there, and the carbamide peroxide is time released. It takes 4 to 6 hours for the reaction to be complete. That's why you'll see carbamide peroxide in your nighttime products, and there's a longer exposure time because it's inside of your tray while you're sleeping for 6 to 8 hours while you're sleeping. Also, there's less salivary flow. And for some patients, it's easier for them to be compliant and wear these trays at night. I have many patients that wear Essex retainers at night, and they're so used to wearing Essex retainers because they've been in Invisalign for years. So it's very easy for them to either place the carbamide peroxide product in their Essex retainers or into the softer softer trays that I make for them. So the patients can become more compliant. The other confusion that we have are the numbers, and every product line comes out with different percentages of hydrogen peroxide and carbamide peroxide. So what is kind of cool is they go, oh, I'm using 30%. Oh, I'm using 38%. Well, basically you have to look and see, are they using carbamide peroxide or are they using hydrogen peroxide? Because when you have like a daytime product, you're going to be using 6, 9.5, or 14 on the hydrogen peroxide, and it's going to be a lower number. Because remember, the carbamide peroxide is going to break up into 3.5% hydrogen peroxide. And so you have to always look at what it is. So when patients come in and I don't know what their product is, because they always ask me if it's okay, I tell them everything's good. They're all different. We're going to go over why they're different. I go, take a picture of what you have at home and text it to me or email it to the front desk so I can tell you how to utilize the product, or whether that's a product that's working for you, or if it's too strong, or if it's causing sensitivity. Now, teeth can only change at a certain rate. Everybody's teeth respond different in how white they get and how quickly the whitening will occur and how long it will stay. And I always tell patients, it's kind of like, some people go and they get a suntan and they walk outside and in one day or in 20 minutes, they're dark. Other people, they get red, they never hardly get a tan. They could do 20 minutes a day, and maybe they'll get a little bit darker. And so everybody's different and your teeth are different. I always try to explain everything with working out or your skin in a suntan so that we can dummy it down to everyday life so people can really understand. Some people, they just don't get that white, and other people get super, super white. What else is different between the carbamide peroxide and the hydrogen peroxide is that the carbamide peroxide in the pH, the saliva is elevated during bleaching because of carbamide peroxide. The byproduct is urea with carbamide peroxide. The pH of the saliva is normally 6. When you use the carbamide peroxide, it changes the pH of the saliva from 6 to 8, and it makes your mouth basic. And that's why you use carbamide peroxide, when you want your mouth to be more basic. The critical pH for demineralization for enamel is from 5.2 to 5.5 pH, and for dentin, 6 to 6.8. The urea is not in the hydrogen peroxide. So hydrogen peroxide pH in the saliva is 5. So you're more acidic with hydrogen peroxide unless they put extra product lines in there, additive ingredients. Urea is not in the hydrogen peroxide, so it's going to be more acidic when you're using the hydrogen peroxide. So how do you utilize this, and what are you thinking about? You're thinking about your patient's caries risk. If you have moderate or high risk caries with patients that are having decay in their mouth, and you know that caries is going to have an acidic environment, you're really thinking of going basic, and you're going with a carbamide peroxide product, or erosion or anything along those lines. You're looking at carbamide peroxide because you don't want an acidic environment. But all products are not created equal, because different product lines not only have the hydrogen peroxide in them, but they add additives in. So they've tried to get around this to help the teeth. The pH is acidic for packaging. It makes it stable. And that's how they have to package it. They have to get it to us, etc. Okay, but it's more of a poor whitening result. And it's not as good for the teeth, but it extends the shelf life. pH is basic for optimal oxidation, 9.5 to 10.8. So if it gets to be too high up, it bubbles and it's not good whitening anymore. So we have raising the pH of the hydrogen peroxide so that it will be more effective, but we have to do that, and we have to balance it with shelf life. So the efficacy of the hydrogen peroxide is present when you're ready to use the product. So this is kind of a balancing act the manufacturers have to go through. It's really been difficult. So they've added all these ingredients, and they've added dual barrel syringes. And that's why I utilize these products, because now they can have one part of the product in one part of the syringe and the other in the other part of the syringe. And then when they come together at the end of the tube, it works better. So you have a pH raiser on one side, then you can have ACP, fluoride, and potassium nitrate. We will talk about it with the whitening gel on the other side when they're getting extruded. So that's how they've gotten around it. Now, if you have a product line that you're using that doesn't have this technology in it, then just tell your patients, do not brush your teeth for 30 minutes, because otherwise they are having an acidic environment and they're brushing their teeth and they're taking that toothbrush and they're giving it abrasion with acid on the toothbrush. So we don't want them brushing their teeth for 30 minutes. If it's really highly active of a product line, they will tell you you have to refrigerate it. And so also with the Zoom, when you get the boxes, you have to put it right in the refrigerator, the whitening gel, because it will not work. It will deactivate the product line. So you have to know which ones have to be refrigerated and which ones don't. Also, you have to really know these things, or else you're going to utilize product that doesn't work, and then you're going to think, oh, this stuff doesn't work, but it's because you didn't handle the materials appropriately. So another question my patient asks is, how long is it going to take? How long? All the time. How much longer? How many more minutes? For maximum results, we have to increase the concentration and we have to increase the treatment time. But when you do that, you can increase the sensitivity. And then that's when people get really upset. They don't want to ever do it again. They're scared. They hate pain. And this is when you lose them. So you have to be very careful on how you handle these patients. The best thing you can do is when you first meet a patient, you can ask them, how sensitive are your teeth? Like, can you eat ice cream? Have you done whitening before? Did it hurt your teeth? Tell me your history of everything, whitening, cold, everything. You look at their teeth too. I mean, is there gingival margins around the zenith of the teeth? Is there no enamel? Do they scrub it all away? Is it gone from acidic environment? And then are they more sensitive? Then you ask them all of these questions ahead of time, so you can know which kind of product to give the patient. Now, this is me again, and I have little pulps, and I'm not sensitive at all. I can use the strongest product, and I just use it on the plane for 45 minutes. One time I'm done, and it doesn't hurt me at all. I'm never sensitive, and I can get pretty white still. No sensitivity, tiny little pulps. And again, I have enamel at the gingival margins. I'm not sensitive. Now, younger kids, a lot of them have big pulps, and some of them are very, very, very sensitive to cold. They can't wear their trays. They can't wear it for 20 minutes. So why does a tooth become sensitive? What's going on? We have Brandstrom's hydrodynamic theory, and everybody knows this. We're going to review it. Stimulants cause fluid movement within the dentinal tubules. Then once there's fluid movement in here, back and forth, then it stimulates the nerve fibers. Hypersensitivity occurs when the hydrogen peroxide breaks into water and oxygen radicals, because it permeates, diffuses through the dentin and the enamel, and then it permeates into the pulp. Once it permeates into the pulp, the oxygen occupies space in those tubules, right in here. And then it creates a lot of pressure, creates pain, it's transient, and it's reversible. So we have all these strategies to minimize sensitivity. Different products, different ingredients within our desensitizing gels. And we're going to talk about each one and what it does and how they work. ACP is amorphous calcium phosphate. It fills the open dental tubules in here. It crystallizes into hydroxyapatite. It delivers enamel protection and microhardness into the enamel, and it helps improve the luster of the enamel. So here's our relief gel. It has 3 products in it, but ACP is one of them. Now there's other products that we also can add. And in this companies, they have potassium nitrate and fluoride, both in their gel. Now, what does potassium nitrate do in the strategy to minimize sensitivity? This solution prevents repolarization of the nerve. So this one is working on the nerve side, so it doesn't repolarize. We have all these exposed root surfaces. We're going to evaluate the teeth first. Now, would we want to trim this tray long or short? In this case, you may want to think about trimming it shorter and keeping it off the gingival margins of where we're going to maybe place these class 5 restorations that we need to go in and restore. So we would think about cutting these shorter. The root doesn't really bleach like the rest of the tooth, so you could even think about restoring these teeth early before you start to whiten and then make the trays. So these are conversations you're having with your patient. You can use a translucent composite that can have a chameleon effect to pick up the color on the margins. And you can always go back and resurface them after the fact if the patient gets super, super white. So this is where you can decide, do I want to restore early or do I want to restore later? I tell my patients that don't want to restore early that you can use a relief gel at the cervical margin and hydrogen peroxide in the middle. Sometimes they don't really understand it, so I show it to them like this. So again, at the gingival margins, we're going to have relief gel, and at the tip, so when the tray goes up over the teeth, the medicine portion is toward the gingival margins. If they don't understand it, and I put a drop, I show it to them here, here, and here of the relief gel. Then I have a drop of the night white or day white product, carbamide peroxide, hydrogen peroxide here, here, or here. And then I put the tray over the top. Now there's all other kinds of strategies and product lines out there, but this is one of those that you put in the mouth, just like the video I showed you, that has potassium nitrate in it from Ultradent. This prevents the repolarization of the nerve. So these are, you just put them in your mouth, you peel off the green, and you leave them on for 10 minutes. So people that are super sensitive can always come in and buy these trays and put them in when they get done with their whitening. And that helps a lot. Then we're looking again for maybe toothpaste that has calcium phosphate, hydroxyapatite in them. And then you can utilize these toothpastes before you start the procedures a couple weeks before whitening. You're looking for these products, and then you can pre-brush, and this is another one. Sensodyne works really well. We use an electric toothbrush for 2 weeks with these products. You're looking for products that are free of sodium lauryl sulfate, and this will help desensitize the teeth, still use the whitening, and they won't be sensitive as much after the procedure. So we have strategies to reduce sensitivity. I always look at this as like working out. I tell my patients that. So if I work out and I'm super, super sore, then the next time I go work out, I'm not going to work out as long. Like say I hiked for an hour, so I'm going to hike for 45 minutes. So I tell them the same thing. I look, okay, so you're going to wear your trays. How many minutes are you wearing it? 60, go to 45 minutes. And if you're wearing it 45 minutes, go to 20 minutes. The next thing I tell them to take a day or 2 off. Just like I'm working out, I'm sore, everything hurts, I'm not working out for 2 days. Let everything calm down, and then I'm going to go work out again. So don't wear your trays for a couple days and then start up again. Then I'm looking at the concentration of the hydrogen peroxide, and I'm looking at the concentration of the carbamide peroxide to see whether these patients should take it slower and use a lower concentration of the product lines. The lower concentration is around 6%. It's very, very gentle, hydrogen peroxide, and then also looking for products that have ACP in them. So they have desensitizing gels inside of the products. With these, you're thinking 1 time per day, 30 minutes, optimum results, a couple weeks, and take a day or 2 off if you're sensitive. and use trays afterwards with desensitizing gel. This is a next, it keeps going higher. This is 9.5% hydrogen peroxide. This is for someone that's not sensitive and they want to get whiter faster. This maybe take 1 or 2 days and you're going to bring your white back. A product once a month, I would say, in my mouth almost always once a month, I'm putting it in to keep my white. And that's what I'm using as a 14% because I don't get sensitive. And that's what I used today on the plane getting here. I had it in for 45 minutes. I put the timer on while I'm working on this presentation and take it out and I'm done. But again, I'm not sensitive. I don't have any nerves that are killing me here. So you have to really follow with your patient as to what their sensitivity level is. The differences in the products is the concentrations of the hydrogen peroxide. So whatever company you're using, look at what you have. What are they using? Hopefully this is going to clear up some of the confusion. Also, if you can use a product line that has ACP in it, fluoride and potassium nitrate, then you're going to have desensitizing gel right in it, and that may help also. This is your opalescent products, and in theirs they're using carbamide peroxide. They have fluoride and potassium nitrate is what they're using in their product line. So again, you want to utilize companies that have some additives in these areas. Now, we always have this big discussion about the light. Why are you using a light? Does it work? Doesn't it work? And then there's so much literature that was out there. But the most recent literature, and I'm going to quote a bunch of literature coming up, is, in my office, it works. It is the quickest way to get a person white and for them to get motivated. It jumpstarts them. Totally jumpstarts them. Now, if somebody was going to go home and use the trays, the outcome is the same if they use it every day. So you don't have to do the in-office procedure. So if you can get someone to be compliant and utilize their trays, you're not going to have any issues. But a lot of my patients are lazy. They're not compliant. They don't do it. And so I'm sitting them down and I'm turning them, I'm converting them into an in-office procedure. Now, 7 days of at home is the same as an hour of the light, or 20 hours at home can be the same as an hour of the light. So it really varies. So people go, oh, what am I going to get? I go, I don't know. It's going to vary. But no matter what, I show them before and after pictures of the best case scenarios and the worst case scenarios. It's still going to work. And then you're going to know whether or not your teeth can really get whiter, because they do vary. Now, there's different brands of in-office concentrations of hydrogen peroxide, and it ranges from 25% to 40%. This is an article that was published. These are all the articles that were published, and evidence-based protocols utilizing the LED whitening lamps in Inside Dentistry. The most recent article, though, came from the Journal of Aesthetic and Restorative Dentistry, and it was not supported by any company. And I love the journal. I really believe in the honesty of this publication. That's how there's no way that it wasn't done appropriately. They took the efficacy, which way was more efficient as far as the light versus a non-light. So they had patients with light, they had patients with the non-light, with the in-office procedure. So the Philips White Speed had a greater change in overall color at 7 days than Opalescence Boost with no light. And so the light does make a difference. Also, an electric toothbrush maintains the white best over a manual toothbrush. So I'm making sure my patients are using an electric toothbrush so they're not getting the extrinsic stain at all, so that their whitening results can be more predictable and have longevity. Here's another article that was in Clinics of North America showing how the light works, and it really does jumpstart the procedure. In office, 25% with the light is proven to be the best absorption kinetics. It whitens better. So my question to my patients are you compliant? Are you do it? Are you lazy? So I need to bring you here, put you in my office, put a video on, a music video, and let you watch this while you're going to have this procedure accomplished. And my line is instant gratification takes too long. My patients, a lot of them, they're very, very impatient. They just want to be done. So here are the before and the after pictures that I show my patients. And I show them this picture to this picture. And before, this is an older picture. Now you'll see this color. I go, this color is like here. Now your color is over here. This is my in-office whitening procedure. And this is what you're going to look like. I'm using the 25% hydrogen peroxide in the Philips Zoom. You have to use a dam. So you have to use this along the side here. Okay, then the whitening gel goes over the top and you put it on for 3 15-minute sessions. So one time you put it on, you wait 15 minutes and then you suck it off, and then you put another session on and then you suck it off. So you go 3 times. I tell my patients I want them to go 4. So I push them for 4. And then when they're done, I don't take it off. Put more, if there's any tube left in the tube of the whitening gel, I put it back on there and leave it on there, and then I take everything off. So this is a patient that was a dentist that didn't believe that this was going to work. He began as an A2, and when he was done, he was an O2O. So always have this before picture. And I always say, what shade of yellow? A2. Then I say, what shade of white are you now? O2O. Oh my gosh. I take this picture and I email it to the patients. Once they have it in their phone, they can go to Instagram, they can send it to their friends, but they feel value that, oh my God, look at it, worked. Plus I have documentation. So I know what color they can be. So when they come back in for their hygiene checks and I can see that they've gotten yellower, I can go, hey, you were this color before, you can do it. Again, it's like going on a diet. You were this weight before, you can do it. It's just compliance. And unfortunately, I tell patients, all of us have to do something all the time. We have to do our hair, we have to do our nails, we have to whiten our teeth. It really helps us feel better about ourselves. And there's many companies and manufacturers over time that have said, you know, once you whiten your teeth, you have to have a white diet. Specifically, if you're utilizing the fast Zoom, you know, the light activated. And if you have a white diet for the first couple of days, it's better. I don't really utilize that anymore because it really discourages my patients from bleaching and whitening because they're like, oh, it's not going to work. I want red wine. I want coffee. I have to have coffee every morning. And I really think that if you even use your at-home trays once or twice a month, it just mitigates the coffee problem. And it really has a minimal effect on the color of the whitened teeth. So I don't really worry about it. Now, once I've done a Zoom Power whitening session and it's really white and I take this after picture, I always have to tell my patients there is going to be initial relapse, at least a half a shade on most people. And before I do any bonding or cosmetic dentistry, restorative dentistry, I want to wait about 2 weeks because the color is going to fade. Then I'll know exactly what color to match. And the bond strength, if I'm bonding composite, is going to be stronger. Now, this is a patient who had veneers on the upper and whitened the lower teeth. And you can see how when the person smiles, it almost looks exactly the same color. So I tell my patients, if you whiten lower teeth and put really white veneers on the top, it is like shooting a moving target. It's going to keep changing the lower. And so over the next 5 years, you really have to use some whitening gel in an at-home tray. And if you don't want to do it and you're not compliant, then you may need to sit in the Power Whitening Zoom machine. The lower color will restain. Now, you can always tell the whiter teeth are on the upper because it's going to show more contrast. So if you whiten upper and lower teeth and you had natural teeth, you wouldn't necessarily know that your lower teeth were going to get darker or your upper teeth. But when you put veneers on the upper teeth, then you have a match and you can see it. And you're going to have to commit to a touch-up. I always look at it like I'm getting my hair dyed. I have to retouch up my hair if I get my fingernails done. And so it's a cosmetic procedure and the patient must be compliant with the touch-up. Usually it's 1 or 2 days per week at-home treatment. And some people are 1 or 2 days a month. It depends on how yellow their teeth get, how quickly they fade. And again, it varies amongst the different patients. So here again, you can see the pre-op of the different color of the upper teeth that were veneers with the lower teeth that after the 5 years, because he didn't come in for 5 years, how yellow they had gotten. He did a power zoom. And when he was done on that day, it was whiter, the lower teeth, than the upper teeth. It went from an A3 to a BL3. And that's a great result. It's beautiful. And he's happy. Will he be compliant? I don't know, but I do know I have this photo and I sent it to him in an email. And so if his teeth start getting yellower, then we can always bring him back. But I also, when I take these photos, I can see if they're grinding, they're not wearing their night guard because I had put some bonding there. And then I can tell the patient, hey, you need to come back in. I need to check the bite and the occlusion. I need to see what's happening. And I can add some more composite on these edges so you have longevity of your own teeth. So the photographs are going to help expedite more dentistry for the patient to keep them predictable and the longevity of their natural dentition. So what was wrong with these older lights? They were high intensity halogen lights and they created way too much heat and the tooth got super sensitive. So that's why people go, oh, I don't want to use a light. It hurt too much. So what's great about the temperature is that it speeds up the reaction rate. So for every 10 degrees Celsius, the rate is doubled. So now they've changed everything and we have a blue light and it's an LED blue light and has a very narrow spectrum. It's powerful and it has very little heat. You get zingers and the zingers at times can be from overexposure to the heat from the lamp and it increases the intrapulpal temperature. It rises. And so while the patient's in the chair, you must monitor their symptoms. And the new light, you can turn down the setting. There's 3 settings. And so if someone's sensitive, I bring it down from high to medium to low. So I have control now, which I love control. Now, the second reason that we have a blue light is because we have photon energy from the light and it causes the pulpal neurons to produce high levels of substance P. Now, substance P accelerates the degradation rate of the hydrogen peroxide. It increases the hydroxyl radicals and it breaks down those chromophore chains. So whitening resistant teeth are striped teeth, gray teeth. So when I see these, I'm going to tell my patient, these are harder to whiten. These patients will have a Zoom and then they're going to have a take home night white and they're going to have to do it for 3 weeks at the minimum. And then we can monitor the color and see whether they need to do it for a little bit longer. It's called dual whitening. And here's a pre-op to a post-op of a patient that had dual whitening accomplished. And you can see the only tooth that really didn't whiten was the dead tooth, which was number 25, the lower central incisor. That's the only one, and it needed a root canal and internal bleaching. And so you can have a really good color match there to see that this does work and it's minimally invasive. Now, Core is a different manufacturing company, and they do it the opposite way. They want you to first do it at home and then come in and do it with the light, their light, or their in-home. And so basically, when you have striped teeth, you must know it's going to take longer and you might need to do dual whitening. Doesn't matter what order it's in, but you have to do dual whitening. Now, what's confusing about when you have decay and you want to whiten their teeth? So you do an exam and you have caries present, as you can see in the photograph. So when do you restore before you whiten? And when do you restore after you whiten? We're going to go through each of these categories so you're not confused. So you're going to restore before whitening when you have deep decay and it's sensitive. You're not going to whiten right off the bat. You're going to do what you need to do with the tooth. And if for some reason that tooth has composite on the facial, you're going to whiten the whole dentition after the filling has been placed. And then you may need to resurface that facial composite. You don't even need to use any anesthesia. You just take it off, etch and bond, and put a whiter composite on the facial. Because this tooth, obviously, you need a liner. It's really deep and you don't want a root canal. So you're going to restore before. When am I going to restore? After whitening. Due to the side effects of the carbamide peroxide, remember that when it dissolves, it goes between urea, which is really basic. It releases that. So if you have superficial caries, the caries is going to be arrested during the whitening treatment. So if it's superficial, I'm using carbamide peroxide because it's going to help. It's a benefit. Also, I have a case like this. Maybe I don't even need to replace the restorations because the restorations might match the new whitened shade once the whitening is completed. And if it doesn't match after the whitening is completed, then I can go in, replace the composite in those areas. On the patient's left, he has 2 crowns. In 8 and 9, I always ask them, did your front teeth match when you got those crowns? Yeah, I remember them matching. Well, then that's a great, easy fix, which is just whitening. And then in that case, you don't have to replace the existing restorations, but maybe the filling. And in this case, I had to replace the filling. Look at it. It had some micro leakage, some black areas. It was pretty ugly. And after the one side, which has the crowns, I did not replace the restorations. And the other side, which have the composite restorations, look at how beautiful and imperceptible the composite is after we whiten. Wait 2 weeks. Now, what looks worse when you whiten? Gummy smiles with short teeth. Why? Because it's even whiter and it even shows more the pink, the contrast. It looks worse when you whiten. So someone like that wants to whiten, I'm going to go, hey, listen, you might look worse. You might want to think about another cosmetic procedure. Also, when the gingival margins don't have harmony, like 7 isn't the same as 10, a canine's in the lateral space, the pink backdrop is all messed up. Well, once that happens and you whiten the teeth, again, the contrast is going to be there. It's going to look worse. So you want to tell the patient that. Then patients have white spots. Hypocalcification. This is a patient that we debanded because he didn't brush his teeth, and we're going to go ahead and do some restorations later, but he's very young. And we thought just to kind of jumpstart him, let's whiten his teeth. So I tell him it's still going to look speckled, but it's going to look better because the white is going to be closer to the new whitened body shade. And so it's going to look better, but we're still going to have to do restorations. So from far away, when he's smiling and talking, he's happier because the white spots are less noticeable. Now, all of these future cases we're going to show are on my website, smilesbyjoyce.com, the publication page. So anything that I do that goes pretty fast, I have a couple articles, as I've said earlier, that are published. So you can read them and it has all the detail in the articles. And this was from November of 2017. And that's Smiles by Joyce publication page. And I always say when I lecture, I put a picture up and I go, what dentistry has been performed? Because if you can see my dentistry, then you're not going to want to listen to me for the rest of the podium talk. And if you can't, and it's imperceptible, I believe, then that's what our goal is for the patient, and they're going to be happy. So the patient fell and her teeth were yellow. This is her pre-op and it's all broken. So the first thing I'm going to do is I'm going to do an at-home treatment for her, and she could do Zoom and at home. But when I make the tray, I'm going to take the model and I'm going to add composite where I think I'm going to add the composite in the final restorations. So if she uses it as a tray for the relief gel, or if she uses it for at home, then she can not have to make another tray. Because look at how fat that tray is. I made it fuller in that area on purpose because I'm planning for the future. Taking the model, I'm adding to the edges. Now the goal is imperceptible from the pre-op to the post-op. So she started with Zoom, then she was at home, and she waited 2 weeks before I did any bonding. Now I love Empress Direct by Ivoclar. I believe the colors that are in there really help me because they have really beautiful whites from my whitening cases. And so I can match the color. Now I'm going to look at many different opacities when I'm going to do a case like this. And so number 2, as you see there, is the front, and it's the effect enamel. And it's going to be on the back of the tooth. And I want it to be very translucent so that I can bring in the modifiers and the color that is going to be the dentin color, and it shows through with the translucent composite over the facial of it. So I'm going to use different whites in these areas. Then I'm going to use a white across the bottom. That's my white halo because I want to match the tooth that is a contralateral tooth. So that's an extra white color. And then I'm going to put a body color over the facial. The next thing I'm going to do is look at the tooth next to it, and the surface texture I must mimic. And I'll put the diamond right in the area, and at a very low resolution, I'm going to barely touch the tooth in the area and give it the rippling effect that it needs. It's a secondary anatomy. Then I'm going to polish over the top lightly because we want it to have ripples in it. We want that anatomy on the facial to duplicate and mimic the contralateral teeth. And that's why it really helps and makes it imperceptible. It's a combination of all of these things, whitening and utilizing the composite in the proper layers, colors, translucency, and then knowing how to handle the surface facial texture. So after whitening, she appeared like this. And then after the completed composite restorations, she appears looking like this. And these patients are happy, and it's minimally invasive, conservative restorations. Again, this is published. You can see it a little bit slower. Whenever I have patients that have composite restorations, I always give them a post-op sheet because they have to understand what they have to do. They can't use abrasive toothpaste on them. They could break them if they bite and tear into them, etc. And so I always have them have a post-op sheet. And you have to know it's all about the smile because that's all they care about. And this patient, I could barely get to smile. And now he's a movie star in California. And this is the most I could get him to bring his lip up. I couldn't get a high smile on or a Duchenne smile on him. He hated his teeth. And so the first thing I did after I took all my photographs was I showed him a case that was completed, a pre-op to post-op. I go, look at this guy. All I did was whiten him and do some bonding. So let's start with the whitening procedure. So here he is, the yellow, the white spots on the bottom, combination case, and it's disproportionate right side to left, and everything doesn't look right. And he says, I don't really care about the bottom teeth. I don't care if they're crooked. I don't care about the color. And again, I'm always going to take this pre-op photo so they have a way of comparing. And then he goes into the Zoom, and we wait 2 weeks to start the whitening. And now, all of a sudden, he goes, oh my God, he's starting to look at his teeth. And now he wants more restorations. He wants the incisal edges of 8 and 9 done. He wants the brown spot removed. He wants the facials of those teeth on the lowers, the white spots removed. And we went right with bonding because he was going to California. We don't have time to do anything that wasn't quick and fast. And so we went ahead and etched it and we bonded it. We layered the composite. And then this is the final of the maxillary arch. And this is his pre-op smile to his post-op smile. And look how much better he looks. And it's his own natural teeth. Now here's pre-op on the lower to post-op. Still looks like his teeth. He still has a little bit of white spots, but no 2 light bulbs glaring at you. This patient presents in hygiene. Now she had all of her upper teeth already veneered. And I'm getting down. I'm like, your teeth are yellow on the bottom. Do you have 10 minutes? And she goes, yeah, I have 10 minutes. She hates the lower teeth. She can't stand to use her trays. And she didn't have time to get into the Zoom power whitener. I was checking her bite. I noticed, that her teeth were yellower. And I go, it's like shooting that moving target. But I have a new product that I can try on you. It's called Quick Pro Varnish. And what this does when my pre-op to my post-op is you're putting the product on and you can let them go home and then they can pull everything off in 30 minutes and it really jumpstarts them. So she's somewhere between an 040 and a 1, a B1. And the lowers are a lot darker. So I'm going to take that before picture with my cameras. And it's an 040 on the lower. Between that and an A1, that's a B1 to an A1. So I always put both colors in so they can't think I'm cheating, because the gingival margins are a little darker, the incisals are a little bit lighter. And now I'm going to put, these are little tricks. The little cotton there is to go and buy the parotid gland so that there's no pressure from the retractor. It makes it more comfortable for the patient. We put those in, and the first layer is 20% hydrogen peroxide. And after we put our dam along the gum line, then we're going to put that first layer on, and then we're going to put a light on that first layer. We're not going to put the second layer on too heavy. I did put it on a little bit heavy, and it doesn't really matter, but that second layer is going to seal it in. So you're going to have a controlled, sealed area. And now they can go home if they want. In this case, this patient waited so that I can take the after picture. And you wait 20 minutes. And here, you're going to peel everything off after 30 minutes. And now you can see, before it was an A1, it was much yellower compared to the upper teeth. The lowers now are 020, almost the same color top to bottom. Look at that when she smiles. Not the same, but much, much closer. Jump starts the procedure. So pre-op picture A1, post-op 020. You always take this photo. It really makes a difference for me. Then you can put little arrows on pre-op to post-op. Again, a jump start. So I take a picture, I send it to the patient. I ask for a Google review because I don't have enough Google reviews. And it really helps the patient feel good about spending the money, the time, and the energy whitening their teeth. So whitening is the entry point for all of my cosmetic cases. So I hope this presentation helped you better understand whitening, because I believe it's going to help patients. Their self-esteem is going to increase. Every time they smile, they're going to feel really good. I know it's going to help increase revenue, because once they have a beautiful smile, they're going to look at their teeth and they're going to want bonding, etc. So it's really going to help in that manner. So I really want to thank you. And any questions, please go into the chat site.